Dear friends, greetings for the day. In this short video, let me demonstrate the microvascular anastomosis in a medium-sized artery of approximately 3 mm. The procedure is done under a microscope with a magnification of approximately 4x. After applying the approximation clamp using the clamp applicator, place a small piece of cut gauze piece under the anastomotic site. This will stabilize the area of interest and also keep the vessel wall ends everted, which will help in anastomosis. The background colored material, usually a polythene sheet or a small glove piece, is placed above the gauze piece. It provides a contrast background while taking the sutures and also provides a smooth passage of sutures without adhering to the gauze underneath. Then adventitiectomy is done. This is an important preparatory measure before the actual anastomosis. Adventitia is thrombogenic and hence it has to be removed at the site of anastomosis. It is a good and safe practice to remove the adventitia of the entire vessel wall within the clamp or at least a minimum of 2 to 3 mm from the vessel edges. The fluffy tissue in the vessel wall is gently pulled and cut. Ensure that the scissors is placed in the same plane of the vessel wall to prevent any inadvertent injury to the vessel wall. The adventitiectomy is done both on the anterior and posterior vessel surface. Develop a habit of placing the cut adventitious tissue in a separate gauze to avoid sticking of the fluffy tissue to the instruments or contaminating the anastomotic site. Gentle saline irrigation will show up any residual or loose adventitia in the vessel wall, which could be removed at this time. The vessel ends are brought closer in case if they are apart. Then the final adjustment of the background and the gauze piece is done before starting the anastomosis. The suture material we are using in this case is 8-0 nylon. The other commonly used suture materials are 9-0 and 10-0 nylon. What we have to specifically look for is the needle tip, which should be a micro point, and also the tip size, which is 150 micron in this case. The suture comes with a unique number for each of the model. The 10-0 suture which we use generally has a tip size of 100 micrometer and a 5 mm needle. The sutures are generally long and it can be cut as shown here, as shorter threads are easy to work under microscope. Hold the needle as demonstrated here. The first suture is taken at 12 o'clock position. Pass the needle at 90 degree to the vessel wall. Then pull the thread gently and then pass the needle again at 90 degree inside out through the opposite wall. 3 knots are generally taken for each suture. The first knot is a surgical knot with double throws and the following 2 knots are single throws. Now we are taking the first knot, which is a surgical knot with double throws, and the following 2 are simple knots. The next suture is taken at 6 o'clock position. This pattern of anastomosis is called the halving or the 0-180 degree technique. The other pattern is triangulation, when the initial knots are taken at 0, 120 and 240 degrees and the remaining sutures are taken between these 3 key sutures. Joyless forceps is placed in the lumen while taking the sutures. This provides a counter traction and also avoids a posterior wall stitch. The sutures are taken at equal intervals without any gap in the vessel wall. Also, the sutures are taken at appropriate distance from the vessel edges, sufficient to hold the sutures. Too distant bites will cause inversion of the vessel wall, and sutures taken very close to the lumen can cut through. Another important technical tip for the success of microvascular anastomosis is the eversion of the vessel edges. This is done by gently pulling the suture ends while tying the knot. Here is a demonstration of the same. While tying the knot, gently pull the knot away so that the edges are getting everted. Now I will demonstrate how to tighten the knot if it is loose. Just hold both the ends and gently pull to tighten it. This is the final suture of the anterior wall. Once this is complete, all the long suture ends are cut. It is a good practice to place the needle in the soft platform of the suture foil to avoid misplacement of this tiny needle. The clamp is turned 180 degrees to suture the posterior wall. Usually, some residual adventitial tissue will be present in the posterior wall, which has to be removed. At this point, the anterior wall sutures can also be inspected through the lumen. The first suture in the posterior wall is a simple suture as we did in the anterior wall. For the remaining part of the posterior wall, let me demonstrate the loop suturing techniques. Here, multiple loops are taken at a single go, then each loop is tied separately. The major advantage of this technique is that the vessel lumen is well seen for each of the needle pass, so the chance of error is minimized. It also marginally saves the time. Now we are taking the loops one by one. For this distance, approximately 4 loops are taken at equal intervals. For the beginners, patience and concentration is required while doing the loop sutures, or else it may end up in jumbling of the sutures. A good assistant can also make this technique very easy for the surgeon. Now the loops are completed, so just then gently push all the loops on one side and start tying the knots. This also can be made easier by decreasing the magnification in the microscope, which gives a greater field of vision. While doing the loop suturing technique, avoid irrigation as this can cause sticking of the suture materials and the loops. Once this is done, again all the long suture ends are cut and the clamp is released. To verify and cross-check the quality of suturing, you can cut the anastomotic site and open the lumen and check it under the microscope. A good suturing or anastomosis will have equally placed sutures without any intimal damage and also without any posterior wall stitch. As you can see here, a well placed and equally placed sutures without any intimal damage. Thank you for your patient listening.